Welcome to today's episode of our lecture. Today, we are going to look at a lecture. We are going to lecture on community mobilization in respect of severe acute malnutrition. Look at the key uh, presentation outlines. The key terms are going to be identified and defined. We have to look at the aims of community mobilization. Why must we mobilize community? We look at steps involved in mobilizing community. We look at the stakeholders in community mobilization. And at the same time, we look at the challenges involved in community mobilization. Lastly, we look at monitoring and evaluation of community mobilization. Learning objective. By the end of this module, we should be able to define key terms in terms of community mobilization. We should be able to explain the aims of community mobilization. We should be able to describe the steps in planning and implementation of community mobilization. We should be able to list the stakeholders in community mobilization. And at the same time, we should be able to highlight on the challenges in community mobilization, stroke barriers in assessing those communities. We should be able to list the tools used in monitoring and evaluation of community mobilization. And at the end of the day, we should be able to list monitoring indicators for community mobilization. Let us look at the key terms and aims of community mobilization. The key terms of community mobilization. One is community. What is a community? Community is a group of people, society, population in an area or district, often living within a defined geographical area. They may share a common culture, value, and norms, and they are generally arranged in what is known as social structure. Community mobilization is a capacity building process through which individuals, group, or organization plan, carry out, and evaluate activities in order to improve their health and other needs. It's a key strategy involved for increasing demand for and use of health services. It helps the community to identify, respond, and address their own needs. Another key term is community involvement. Active participation of people living together in some form of social organization and cohesion in the planning, operation, and control of primary health, and at the same time using local, national, or other resources to achieve this. It also increased knowledge and acceptance of community mobilization of acute malnutrition services, that is CMAM. Aims of community mobilization. The aim is to empower the community through increasing knowledge of causes, types, identification, and management of acute malnutrition, and at the same time promoting sustainable positive health and nutritional behavior of the people. At the same time, it involves the community in planning and implementing these services. Increasing service access and uptake, that is the coverage for the management of acute malnutrition, and strengthening early active case finding, referral of new cases and acute malnutrition, and follow-up of problem cases, strengthening the responsibility of nutrition committee to encourage sustainability and ownership. What are the steps involved in community mobilization for CMAM program? These are the steps. We have what is known as the planning step. There are two phases, the planning step and the implementation step. In the planning step, we have step one, that is community assessment. Very, very important. You have to assess that community to find out the level at which they comply with the set out rules in managing severe acute malnutrition. You formulate community sensitization strategy, and at the same time, you conduct training. This training is meant to build their capacity. The other one is on implementation, that is active case finding and referral. In an event where active cases of malnutrition is identified, you now have to determine whether it is severe or moderate. And when it is severe, you refer. When it is, you look at the odema. If odema is present and you take note of your MWAC, at the end of the day, if it is for referral, you refer. And at the same time, you have to do follow-up, which is the home visit and follow-up. And 6, you link with other communities. That is just for collaboration. That is, there are 2 stages involved, the planning stage and the implementation phase. 1, community assessment. It is a key to determine the factors that are likely to impact both services delivery and demand. It's conducted by SMOH, Nutrition Focal Point, and the CHD team with the support partners. Thirdly, it aims at understanding the following aspects of the community that are likely to affect the demand for MIYCF services and most effective way of mobilizing the community to meet the demand for the MIYCF services. This is the pictorial representation of acute malnutrition. Some cultural traditions do not connect severe acute wasting or swelling with undernutrition. We can see from the picture here, some culture did not really look at it as they have fetish belief for such diseases. I never know that it is caused by malnutrition. Step 2 is formulating a community sensitization strategy, which is very important. The people have to be aware of what CMAM is all about. Community sensitization is a crucial aspect of the process of community mobilization. Information gained during community assessment is used for the sensitization. The 2 basic steps to devise an effective sensitization are to develop sensitization messages and 2, to develop a sensitization plan and disseminate such messages. Step 3 is conducting training. Training for the health volunteers. That is, 1, they have to train them on active case finding, identification and referral of identified cases, home visiting stroke follow-up, and appropriate messaging on health stroke nutrition. Training for health facility worker, on the other hand, outreach strategies for CMAM, objective and target population for CMAM, case identification, management and follow-up, health and nutrition education, and how to mobilize the community. Now, active case finding and referral. From the pictorial view, active case finding, identification and referral of identified cases. You can see in this picture, you can see the bilateral odema. What is bilateral odema? It is the accumulation of fluid, and it makes the dentation is there. So the moment if it is identified, then such cases call for referral and home visiting for follow-up, an appropriate message on health stroke nutrition. Identification and referral of children between 6 to 59 months with acute malnutrition at community level. The moment bilateral pitting odema is observed, then such a patient should be referred. Such patient can be said to have severe acute malnutrition, and it should be referred to the OTP, outpatient therapeutic place. Or rather, if he doesn't have, then we should check for MWAC. And MWAC of less than 11.5 cm should be referred to OTP, Mark of greater than 11 point or greater or equal to 11.5 or less than 12.5 cm should be sent to TSFP, and the moment it is greater than 12.5 cm, then no referral is required at this point. Home visits to follow up, that is step 5, are conducted by AHP volunteer on request by health and nutrition staff at facility level. Absentees and defaulters must be identified by through home visit. Children not gaining weight or losing weight or edema, not reducing or non-response should also be identified. Children return home from inpatient care before discharge. Caregiver refused inpatient care. Deteriorating medical condition. These are supposed to be identified, and this can only be identified as a result of home visit or follow-up. Step 6, linking with other community services. Of course, family of children with acute malnutrition should be linked to community initiative for prevention of malnutrition. Uh, they should be able to have food security and livelihood intervention. The IHCF and other initiative must also be incorporated, and social protection and support must be sought after. Role play, identify challenges in community mobilization. Of course, there's no way you mobilize community without its varied challenges. Let us look at monitoring and evaluation for community mobilization. Main activity monitors include frequency and quality of community mobilization activity, that is, number of and variety of community group or key figures involved, number and type of MCG section, MTM and FTP, number of MAMA and MWAC, number of cases with acute malnutrition being referred into the program through active case finding. What are we talking about? We are talking about monitoring and evaluation. And the main reason for default and low uptake from follow-up, coverage monitoring, and community focus must also be identified. M&E, that is monitoring and evaluation community, the tools that are normally used. 1, the community referral slip, the home visit checklist, the community nutrition screening tally sheet, and the community nutrition monthly tally sheet. We have, at the end of this session, we have looked at key terms and definition, aims of community mobilization, the step in planning and implementation of community mobilization, the challenges involved in community mobilization, and the stakeholders. And at the same time, we are able to look at the monitoring and evaluation of community mobilization. Thank you for listening.